dilemmas that we face with our patients in systemic sclerosis. I would like to thank the organizing committee, actually the SSR family, for this kind invitation. I would like to congratulate you all for the very successful conference, and we're almost reaching, inshallah, next year to the 10th conference. So here are my disclosures. Now, let me start with a case scenario. So this is a 43-year-old woman who was diagnosed with diffuse cutaneous systemic sclerosis in early 2022. Her disease manifestations were as follows. So she had Raynaud's phenomenon. She also had skin thickening with a modified Rodnan skin score of 16, so it's like a diffuse subtype. She was also having an inflammatory arthritis that was documented physically. Her disease was also consistent or showing calcinosis cutis as well as gastroesophageal reflux disease. Now, she tested positive for ANA at a titer of 1 to 640 in a speckled pattern. She also tested positive for anti-SCL70 antibodies, as well as anti-RNP polymerase 3 antibodies. Her anti-centromere antibodies were like negative. So, when you are sitting in a daily, clinical practice where you see like 1 or 2 scleroderma patients, for example, in a week or so, you will be having some important, questions that you would like to address when you are seeing your patients. I totally understand that most of the, presentations and work nowadays is focusing on the lung as well as, pulmonary arterial hypertension in patients with systemic sclerosis, and most of the evidence that we have been, discovering and noticing in the past few years is mostly towards these, comorbidities. However, it's also important, to address other, areas that are not very well, covered or evaluated in patients with systemic sclerosis. So the management dilemmas that we usually face, or the questions that we would like to answer in our daily practice, that, for example, when and how frequently should you screen this patient for internal organ involvement? The second question, where does the management of systemic sclerosis stand in the light of the evidence-based medicine? The third question, are you going to prescribe corticosteroid for this patient? The fourth question, would you treat her skin thickening with methotrexate or mycophenolate? The fifth question, what if your PPI therapy for this patient is not controlling her gastroesophageal reflux disease? And the last question that we will finish this presentation with is with regards to the calcinosis cutis and the available medications that can be utilized in the management of these patients. So as you can see that these are daily practice clinical questions that we face in our patients. So let's walk you through these, questions, and let's try to see what kind of evidence and how strong, like we have, in terms of evidence. So we all know that systemic sclerosis is, it's a diverse disease. It's a complex disease that can involve every single organ from the head all the way to the toes. With numerous, morbidities, as well as, increased mortality, especially when it comes to, lung-related mortalities such as pulmonary arterial hypertension, as well as interstitial lung disease. Now, screening is very important, and as you can see that, survival is really, determined by the subset and organ-based manifestations in these patients. So for patients with diffuse cutaneous systemic sclerosis have somewhat, lower survival compared to patients with the limited subtype, and the more like the organs involved in these patients, the lower the survival again in these patients, be it either limited or diffuse subtype. Now, if you look at the upper part of this slide, where you see that on the left side of the slide we have patients with diffuse cutaneous systemic sclerosis, and on the right side we have patients with limited cutaneous systemic sclerosis. We see two lines here that represent two different time zones. So we have the red line, which represents a time zone between 1990 to 1993, and then we have another time zone that is here represented in blue lines, which represent a time that is between 2000 and 2003. And you can see a beautiful dissociation of the curve. dissociation of these two lines when we implemented screening modalities for both interstitial lung disease in the upper part of the slide and pulmonary arterial hypertension. So what does this slide is trying to tell you that screening improved survival in patients with systemic sclerosis associated lung diseases, either interstitial lung disease or pulmonary fibrosis. Now, which of your scleroderma patients will progress? So if you take interstitial lung disease as an example, so patients who have systemic sclerosis, they are either male, they have elevated CRP at the beginning, or they have like the diffuse cutaneous subtype. They have autoantibodies such as the anti-SCL70 as well as the RNP polymerase 3 antibodies. If they have ongoing, for example, cough, so this increased the risk of aspiration pneumonia, and then this also increased the risk of interstitial lung disease. If patients who at the beginning they have low forced vital capacity at baseline, so they are the ones who are going to progress. So if you have these patients, you would rather frequently screen these patients compared to other patients who do not have these poor prognostic risk factors. Now, as of today, the only management guidelines for the management of systemic sclerosis are that are available in the literature are two. So we have like the updated EULAR recommendation from 2017, and we have the British Society for Rheumatology recommendations that were published in 2016. We're waiting and anticipating the update of the EULAR recommendations that should be published at the fourth quarter of 2023, inshallah. So these management recommendations when it comes for the screening part. So how do we screen several organs in our patients? So for example, lung involvement. So any patient who presents with systemic sclerosis, you would like to perform like HRCT as well as physiological assessment in form of pulmonary function testing as well as 6-minute walk test at baseline, and then repeat that on an annual basis or like sooner if there is a clinical indication for that. With regards to gastrointestinal screening, so this is mainly directed by the symptoms that we have in our patients. With regards to pulmonary arterial hypertension, so we are happy to have the detect algorithm that helps us detect and screen for pulmonary arterial involvement in our patients. And please be mindful of the the echo request that you send for scleroderma patients, because we're used to send an echo request that is usually reported as either having like a normal ejection fraction or, for example, normal pulmonary artery pressure. So these are not the parameters that are usually required for patients with systemic sclerosis when we're assessing an underlying pulmonary arterial hypertension. So always write in your referral that this is a patient with systemic sclerosis, and you're looking, for example, for the tricuspid valve velocity, you're looking for the right atrial area, you're looking for TAPC, because it's that time when the echocardiographer will be assessing these important physiological parameters or echocardiographic parameters that will be helpful in determining whether or not you should be sending this patient for right heart catheterization to confirm the diagnosis of pulmonary arterial hypertension in these patients. We do not see renal crisis in our patients nowadays compared to 2-3 decades before, because we're not utilizing steroids as like the previous 2-3 decades. Plus we have the ACE inhibitors that significantly reduce the occurrence of systemic or scleroderma renal crisis in our patients. With regards to cardiac internal organ or cardiac involvement, echocardiography can help, but it also should be directed with the clinical manifestations that we usually see in our patients. Moving on to the second question, so where does the management of systemic sclerosis stand in the light of systemic, or in the light of the current evidence base? So this slide summarizes the level of evidence and the strength of recommendations with regards to the management of systemic sclerosis patients and the organ involvements that they present with. Now, if you look at the right side of the screen, so interstitial lung disease, pulmonary arterial hypertension, digital vasculopathy, as well as inflammatory arthritis. These are the disease manifestations that thankfully gained, significant attention over the past 2 decades. On the other, side, unfortunately, renal crisis, cardiac manifestations, gastrointestinal manifestations, calcinosis cutis, as well as neurological manifestations are still seeking for attention. And we're hoping that with time, we will have more and more robust or type A strength recommendations in the management of our systemic sclerosis patients, inshallah. So let's just show, hands here. So how many audience here in the hall feel comfortable prescribing prednisone to patients with systemic sclerosis? Can you show me your hands? Okay. So how many patients do not feel comfortable prescribing corticosteroids to patients with systemic sclerosis? So it's like 50-50. So let's see why is that controversy in the decision. So if we go back to the clinical case that I started this presentation with. So whatever is presented in green here in this slide, it's an indication for giving our patients corticosteroids. So for example, inflammatory arthritis or maybe skin thickening. What is presented in the red here, it's actually a red flag. So are you going to prescribe corticosteroids for a patient who's showing early diffuse cutaneous systemic sclerosis? How about a patient who's having, anti-RNP polymerase 3 antibodies? So whoever goes in favor of corticosteroids in the management of systemic sclerosis, their rationale is basically, supported by the following. So the inflammatory, component or phase of systemic sclerosis responds well to corticosteroid therapy. So for example, skin itching, for example, inflammatory arthritis. Fatigue has been shown to respond to corticosteroid therapy in some, retrospective and observational studies, as well as, appetite may improve. It's not because, corticosteroids, would have like a positive or direct impact on the appetite. It's rather, corticosteroids will just make you feel more hungry, so you will be eating. On the other hand, people who actually vote or try to avoid corticosteroids in patients with systemic sclerosis is because of the fear of scleroderma renal crisis in these patients, because it's a well-established risk factor. And the rationale of corticosteroids is weaker in systemic sclerosis compared to other connective tissue diseases such as lupus, such as other kind of inflammatory arthritis. So the literature provides a beautiful summary of patients with scleroderma renal crisis, and tries to address what are the either clinical or serological features that are or characteristics that increase the risk of scleroderma renal crisis in patients with systemic sclerosis. So number one, we have so the higher the dose of corticosteroid therapy, the higher the chance of developing scleroderma renal crisis. Patients with early diffuse cutaneous systemic disease, patients who are actually having a higher skin score at baseline, patients who are having positive anti-RNP polymerase 3 antibodies, patients who are having a skin or joint contractures. So these are the patients that you would like to avoid corticosteroid because these are the patients that will be developing scleroderma renal crisis if not treated. So tips for practice. So which are the patients that you should be avoiding corticosteroids in? If a patient is having an early diffuse cutaneous systemic sclerosis, a patient with rapidly progressive skin involvement, a patient who is positive for anti-RNA polymerase 3 antibodies, or a patient who is having joint contractures. If you have to have corticosteroids, then you have to use caution. Do not exceed 15 milligrams PO daily. There was an Italian study that was, pointing towards like a dose of 20 milligram, but recent, literature is, supporting lower and lower doses and taper at the earliest opportunity. Now, if you are using corticosteroids in your patients, so you have to keep an eye on blood pressure monitoring. So we have to educate our patients on how to monitor the blood pressure at least, twice to 3 times per week. You have to educate your patients on the clinical features that might, be pointing towards the possibility of underlying scleroderma renal crisis, such as headache, shortness of breath, flu-like symptoms. And of course, in the clinic, we have to perform routine, serum creatinine check. Do we have alternative options? So we have a couple of patients in the clinic that we have to use the steroids for them because of the, like the myositis component of the scleroderma that they're having. And we all know that we have global crisis of IVIG, so we're not, able to get it for our patients. So we're actually managing these patients with monthly, IM methylprednisone, but we're trying not to exceed 60 milligrams, per injection. The other, alternative option that was presented in the literature is an alternative daily dose or every other day PO prednisone that was also associated with a reduced risk of scleroderma renal crisis in these patients. So this is a slide that might be taken to home with regards to the corticosteroids management in our patients. Moving on to the fourth, question. So methotrexate versus mycophenolate in the treatment of skin thickening. We were discussing, Dr. Rajai, yesterday that you see a lot of differences in the management of patients with systemic sclerosis in different parts of the UAE. And I think the same thing applies here. So we still receive patients who are being treated for their skin thickening with methotrexate. This is not a wrong practice. Methotrexate is cheaper. Methotrexate have been shown in the randomized controlled trials that it might be considered for the management of systemic sclerosis in patients for the skin thickening. But a deeper look into these studies show that both randomized controlled trial use the terminology like favorably. So they say that methotrexate can favorably, improve skin thickening compared to placebo. So they did not use significantly. So, like we're using the terminology in Arabic ala istihya. So this is basically what the function of methotrexate in the management of skin thickening. Now, comparing this to mycophenolate, the secondary endpoint of the SLS2 study that addressed or compared mycophenolate to cyclophosphamide in the management of systemic sclerosis associated interstitial lung disease. So the secondary endpoint was concerned with the improvement in the modified Rodnan skin score. So this was like a non-inferiority study, and as you can see here that mycophenolate was as effective as cyclophosphamide in improving skin thickening in patients with systemic sclerosis. In fact, we all know that mycophenolate is associated with a better safety profile and lower side effects compared to cyclophosphamide. So I think a take-home message in this, always try to favor mycophenolate in the management of skin thickening in patients with systemic sclerosis, unless you have other indications. So, for example, if you have inflammatory arthritis, then you might be favoring methotrexate because it can tackle both. Now, what if PPI therapy for this patient is not controlling her gastroesophageal reflux disease? So we know that esophageal scleroderma can be because of either esophageal dysmotility, peptic strictures, Barrett's esophagus, and many other reasons. So it is very common in patients with systemic sclerosis. It's not always symptomatic. It can happen because of the lower esophageal sphincter pressure, or because of the esophagitis and its complications such as Barrett's esophagus. The way to diagnose it is with the help of the gastroscopy. So when we treat our patients, it's not always just to prescribe a pill. Try to work with your patient in improving or modifying the lifestyle habits, because these can definitely improve gastroesophageal reflux disease in our patients. Despite adding PPI, we still have approximately half of our patients are partial responders. So what should we do in that? So studies have shown that adding domperidone was able to improve gastroesophageal reflux disease in patients with systemic sclerosis, decreasing the percentage from 54 to 17%. On the other hand, buspirone, which is again an anti prokinetic agent as well as it's an anti-anxiety agent, it was also able to improve heart burn as well as regurgitation in our patients. Vonoprazan, I'm not sure if it's available in all over Saudi Arabia. We actually requested for our patients from Egypt. So this is a potassium acid reflux blocker, and it helps improving gastroesophageal reflux disease. It's actually non-inferior to PPI in the management of our patients, and it's also a favored medicine when it comes to erosive esophagitis. There are a few other medications that unfortunately might not be available in the formulary pharmacies in our hospitals, for example, procalopride or other medications that can also be combined with PPI in the management of patients with systemic sclerosis. The last part of the presentation, or the last question, is addressing calcinosis cutis. So basically I will go very quickly because I think I'm running out of time. So any patient can develop calcinosis cutis. There are a few risk factors that you should be addressed in these patients, and the way that calcinosis cutis can happen in our patients is either because of the inflammatory component of the systemic sclerosis, or because of the vascular hypoxia that actually leads to the increased bone turnover, so calcium is being moved from the bone all the way to the skin and deposits in the skin and the subcutaneous tissue, or maybe repetitive trauma secondary to the digital ulcers and manual work. Now, calcinosis can be found almost anywhere. 1 minute? Sure. And of course, deformities and compression neuropathies, ulceration can worsen them. So what are the, the management modalities for calcinosis? So if you have asymptomatic calcinosis, you would be definitely trying to implement the non-pharmacological modalities in the management, and always treat Raynaud's phenomenon and digital ulcers. This will be, inshallah, addressed in the next session by Dr. Namas. On the other hand, if you have symptomatic calcinosis, so again, along with the non-pharmacological modalities, here you can use antibiotics, digital splints, warm salt water soaks, as well as treatment of the Raynaud's phenomenon. Now, management of calcinosis cutis, there were like several treatment modalities that were presented in the literature, such as warfarin, diltiazem. We have rituximab, bisphosphonate, sodium thiosulfate, as well as IVIG. Now, the time really would not allow to go over like the clinical evidence behind all of these medications. However, try to avoid warfarin in the management of these patients. We do not have enough evidence in the literature that supports the use of warfarin. On the other hand, look at diltiazem, how many patients respond to diltiazem. So for example, if you have a patient with Raynaud's phenomenon and calcinosis cutis, so diltiazem would be to go like calcium channel blocker in these patients. Rituximab, showed controversy findings, but it's always a medication in the back of our pockets that can be used in the management of calcinosis cutis and other rheumatic diseases. Again, bisphosphonate also shows like prominent or promising results in the management of calcinosis cutis, and not to forget the non-pharmacological or the interventional modalities in the management. So, ladies and gentlemen, Mr. Chairman, if you allow me to summarize, so survival is determined by the subset and organ-based manifestations. Regular screening improves detection of organ involvement. The use of corticosteroids in patients with systemic sclerosis always requires caution, and weighing risk versus benefits should always be practiced. For skin thickening in systemic sclerosis, methotrexate has not shown to be significantly effective, while mycophenolate is non-inferior to cyclophosphamide. In PPI partial responders, addition of lifestyle modification, prokinetic agents, and/or anti-motility medications may improve gastro or esophageal scleroderma. And finally, there is significant unmet need for better understanding and management of calcinosis cutis in our patients, and more solid evidence is still required. With that, I would like to thank you for your kind attention and listening.